Welcome back to Pharmacology. Today we're going to go through NSAIDS. They are going to inhibit the pain stimulus at the afferent nociceptor, and they can be either narcotics or non-steroidals. The anti-inflammatory drugs, which are steroidals, are going to be your corticosteroids, and there are some that are also non-steroidal. The non-steroidal analgesics are more effective in the inflammatory integumental or musculoskeletal pain rather than the visceral neuropathic pain. So here, the corticosteroids will inhibit phospholipase A at like the very beginning of the whole arachidonic acid synthesis. So by doing this, it also inhibits the platelet activating factor. So it's a pretty good drug, right? So here it stops the arachidonic acid formation, and from there it doesn't make the prostacyclins, the prostaglandins, the thromboxanes, or the leukotrienes. So NSAIDs are going to be the ones who inhibit in this location, or the next step of the cycle. So it's going to inhibit COX and LOX. Aspirin is going to inhibit LOX and COX. And COX-1 is going to be your physiological or constitutive pathway. So these, you need it, right? So aspirin is going to be, it's going to inhibit both, which is not necessarily good. That's why there are those adverse drug effects. Because COX-2 is really what you want to be inhibiting. You want to be inhibiting this because it does form the formation of inflammation. So here, aspirin will is the acetylation of serine 529, and by that it will not form, the platelet activation factors and whatnot. So the physiologic is needed in the renal tissue and the vascular endothelium. That's why too much aspirin is not good. It inhibits the formation of prostacyclins, thromboxane 2, and affects the kidneys, the heart, and the uterus. So this is actually a very good drug for anyone who has cramping during the menstrual cycle. Corticosteroids are going to inhibit phospholipase 2. I'm just repeating myself. Xylutin will inhibit LOX. So it's going to inhibit the leukotriene formation. Prostaglandins, the usage is going to it should be decreased. Pain, inflammation. Prostaglandins do increase pain because it releases substance P, inflammation, and fever. We are trying to reduce the amount of prostaglandins using NSAIDs, right? It also affects the stomach because it decreases HCl secretion, it increases the mucus and bicarbonate production. It will increase the uterine contraction, leading to cramps, and that's due to maintain the renal blood flow. It will also increase platelet aggregation, and the prostaglandin 2 is going to inhibit the platelet aggregation and cause of vasodilation. So it's kind of contradictory, right? So thromboxane A2 will increase the platelet aggregation in the peripheral vessels, but it's going to inhibit the platelet aggregation and cause of vasodilation in these organs, so the stomach and the uterus. Okay, so prostaglandin analogs. Alprostadil is going to be a vasodilator, so it will treat erectile dysfunction and maintain the patent ductus arteriosus. Lubiprostone is going to be given to relieve opioid-induced constipation, along with IBS with constipation. It will stimulate the chloride channels of the luminal cells of the intestinal epithelium increasing the intestinal fluid secretion. An overdose will cause a diarrhea. Misoprostol is going to treat the NSAID-induced peptic ulcer by reducing the gastric acid secretion and increasing the mucus and bicarbonate production. Dinoprostone is going to soften or ripen the cervix, cause the uterine muscle contraction, and induce labor. Prostaglandin F2 analog are going to be bimatoprost, latanoprost, and travoprost, and these are going to treat your open-angle glaucoma. Bimatoprost is also FDA approved to be your eyelash serum. Carboprost will help induce labor, and the other prostacyclin analog is going to be epoprostenol, iloprost, treprostinil, and those are going to be used to treat the pulmonary hypertension. These are not as commonly used as like latanoprost by bimatoprost. Okay, so the non-selective COX-1 inhibitors are going to be a couple different categories. So the salicylate category is going to be made of aspirin and difluzinol. The propionic acid derivatives are ibuprofen, naproxen, and flurbiprofen. Anthranilic acid derivative is going to be mefenamic acid, and the acetic acid derivatives are going to be ketorolac, indomethacin, sulindac, and tolmentin, along with nabumetone. And the preferential COX-2 inhibitors, the ones that we want. Acetic acid derivatives are going to be diclofenac, oxam derivative, piroxicam, tenoxicam. And then the selective COX-2 inhibitor are going to be celecoxib, etorasib, and paracoxib. These are very expensive. The analgesic and antipyretic with no anti-inflammatory effect are going to be acetaminophen. So acetaminophen is going to be used to relieve the pain and relieve the fever, but it's not going to do anything about inflammation. The selective COX-2 inhibitors are going to have less GI irritation. They are going to inhibit prostaglandin I2 without affecting the thromboxane secretion. It's going to inhibit the REYE'S, and it's going to decrease the blood pressure in a way, so it's going to be contraindicated in patients with the coronary artery disease, myocardial infarctions, and CHF. Aspirins are irreversible, and they're non-selective COX inhibitors. It does all this, pretty useful. In doing so, it inhibits PG2 and TXA2, and it resets the hypothalamus and increases sweating and cutaneous vasodilation. In doing so, it reduces fever. There is a cap. You can't give more than 600 milligrams a day, otherwise those will tear a big old hole in your stomach and form a gastric ulcer. Okay, problems. Besides tearing a hole in your stomach, it will also cause uncompensated metabolic acidosis. And the other, symptoms would be dehydration and hyperthermia. The increased water and sodium retention will also aggravate or start the congestive heart failure. Of course, there's increased bleeding. It's going to cause problems and precipitate gout because of the decrease of uric acid secretion. And at high doses, aspirin is going to follow the zero-order kinetics, which is very problematic because, remember, in zero-order kinetics, it's like the metabolism increases logarithmic, trying to say it, but it's proportional, right? So we don't want that. We want first order kinetics, where the metabolism is going to be proportional to the dose, not the time. So we use this to prevent the decrease in renal blood flow. So it's going to help renal blood flow, and it's going to counteract the ischemia. REYE'S syndrome is going to be progressive encephalopathy with hepatic dysfunction in children. So we don't give aspirin to children who are infected with any kind of viral infection. Let's see, it leads to the fulminant hepatitis and then the cerebral edema. Okay, so NSAIDs are going to be analgesic and antipyretic, anti-inflammatory, except for once again acetaminophen and paracetamol. It's going to be antiplatelet drugs. It decreases sodium and water retention, and it delays labor along with the ductus arteriosus closure because of the vasodilation effects and the muscle relaxant. You're going to use it to treat the acute rheumatic fever, rheumatoid arthritis. Well, this is more like a managing the symptom. It's not actually going to fix the rheumatoid arthritis or the osteoarthritis or the gout. This can just help the preeclampsia and the Kawasaki disease. It's going to be given as a prophylaxis post myocardial infarction and stroke for another attack. And it decreases the incidence of colorectal cancer by increasing apoptosis because it's inhibiting COX. The prostaglandin synthesis inhibition is going to cause the gastric mucosal damage, so you want to give omeprazole as a prophylaxis. Because prostaglandin is inhibited, there's bleeding, so it's going to also limit the renal blood flow because of the edema, and it decreases the efficacy of the anti-hypertensive drug because it's literally working opposite. It will prolong the labor and precipitate asthma by the constriction of both smooth muscle. Do not give it to people with asthma. Do not give it to people with children under the age of I think 12, according to the Board of Family Physicians here in the States. You also don't want to give it to anybody with active H. pylori infections, liver disease, pregnancies. Anybody with surgery, you had to stop a week before the actual surgery. Problems: the gastric bleeding, the water retention, edema, the nephrotoxicity due to the renal papillary necrosis is really important. Other signs: there would be tinnitus along with rash and confusion. Aspirin will displace phenytoin, valproate, sulfonylurea, and warfarin. So these two are the most important. Warfarin, because of the 99% binding capacity, it's going to increase the bleeding by 100% every time it's displaced. So problematic. It will cause the hypoglycemia to worsen if somebody's taking sulfonylurea for diabetes. It will work directly against PROSIB, and it can also precipitate the asthma. So aspirin, though a great drug, you do have to monitor it in certain situations. Naproxen is going to be a potent inhibitor of the leukocyte migration, so you use that in gout. Mefenamic acid is going to have peripheral and central action. That can be problematic. We don't want too many drugs to have central action. The adverse drug effect would be diarrhea. Indomethacin will also have GI effects. Neflupam won't inhibit the prostaglandin synthesis. Instead, it's going to increase the activity of serotonin, epinephrine, dopamine, and decrease the inhibitory neuron glutamate activity. It can cause atropinic side effects, so sludge, and it's going to be used to treat traumatic pain, and is pretty good because there is no opioid-like action, so the risk of addiction is a bit lower. Acetaminophen will also inhibit COX-3 and increase the pain threshold. There's no gastric irritation, but it can cause the renal papillary necrosis and the hepatic necrosis. So both aspirin and acetaminophen are decent drugs. They are just double-edged swords. Okay, so acetaminophen is going to be metabolized through glucuronidation and sulfation in the liver, but in overdose, both paths are saturated. So with the saturation, acetaminophen is going to be oxidized into NAPQI, or N-acetylparabenzoquinoamine, by the cytochrome P450 path, and is detoxified by the glutathione. So in an overdose, there's no glutathione, and NAPQI will accumulate in the hepatocytes. It causes the oxidation of the sulfhydryl group, and it's going to increase hepatic and renal cell proteins, and then there is going to be necrosis. The treatment is gastric lavage, activated charcoal to prevent the absorption, and fluids to flush it out. And you want to give N-acetylcysteine to conjugate NAPQI directly, or you can give them methionine. That's it for now. Thank you for your attention, and good luck studying.